Welcome to the Gastro Girl podcast. We bring together patients, experts, and health advocates who are all here to help you optimize your health. Here's your host, Jacqueline Gaulin.
Hey everyone, welcome to the Gastro Girl podcast. This is a special episode on EoE and pregnancy, what primary care and OB-GYN providers need to know about eosinophilic esophagitis, otherwise known as EoE. And today we're joined with Dr. Claire Beveridge, a gastroenterologist in the Department of Gastroenterology and Hepatology at the Cleveland Clinic, where she heads the EoE adult clinic as well as the transition pediatric to adult clinic. Welcome, Dr. Beveridge. Glad to have you back again.
Thank you so much for having me.
Well, this is such an important topic. We've gotten so many questions when we're on site at events, and we're just going to jump right in. So for those who may be listening, could you give us a brief overview of what eosinophilic esophagitis is?
Absolutely. EoE is an allergic condition of the esophagus. It can be triggered by either food or environmental allergens, and it basically leads to an infiltration of eosinophils into the esophagus, which can cause a lot of uncomfortable symptoms, so difficulty with swallowing, heartburn, chest pain, and when inflammation remains uncontrolled, it will lead to scar tissue and narrowing. Some of the most scary complications that can happen would be a food impaction that can sometimes bring patients into the emergency room and then require an emergent endoscopy to remove the food.
Thank you. So there's two kind of channels here. One is for those patients who haven't been diagnosed with EoE, and the other is for patients who have EoE and how pregnancy may impact that. So let's start with, what are the considerations for women wanting to get pregnant if they've already been diagnosed with EoE and they may be afraid or worried? What do they need to know?
I think the most important thing for someone who wants to become pregnant is to kind of understand what their history has been in the past and what treatment has worked for them in the past. Ideally, if we can figure out which treatment works for them, then they can stay on that during their pregnancy. Sometimes it can get tricky if a patient is trying to switch therapies and then find out that they're pregnant, and then we want to try to, limit unnecessary or elective procedures during their pregnancy. So kind of understanding their history is really important in terms of what treatment will work. And then in addition, do they have a history of narrowings? And if they do, then, maybe we need to do an endoscopy with a stretching so that we can hopefully, avoid that during the pregnant period.
So for treatment options, prior, if someone's thinking about getting pregnant or already pregnant, like what are the treatment options for EoE? And does the choice of those treatment options, do physicians need to know, what do they need to know about those for their pregnant patients?
It's a really good question. So I'll just talk about treatment options in general for EoE. So I think about it in terms of two buckets. We have the diet elimination bucket, and then we have the medication bucket. So the diet elimination bucket means, we take away the 6 major food groups that can trigger EoE. We take away those 6 major food groups and repeat an endoscopy in 6 weeks. A good number of patients will have their EoE controlled, about 60 to 80%. Then we can start reintroducing food groups every 4 weeks, 1 to 2 food groups at a time, to see when do we see that spike in eosinophils on esophageal biopsies. And then we can figure out what their food trigger is. Most patients have 1 to 3 food triggers. The 2 most common are dairy and meat. So if a patient has already undergone a diet elimination and they know what their treatment is, which food triggers they need to avoid, that's a very easy, safe way of continuing in their pregnancy. Okay, so now when we think about the medication bucket, the most common one that we start with is proton pump inhibitors, so medications like omeprazole, pantoprazole, and then there are the topical corticosteroids. So that's a swallowed steroid that's not supposed to be systemically absorbed, just supposed to coat the inside of the esophagus and treat the inflammation. And then there's dupilumab, which is a weekly injectable medication. So, proton pump inhibitors, PPIs, have been used in pregnancy before. A lot of the guidelines in terms of OB care would be if someone has acid reflux, that you try to start with, lifestyle modifications first, maybe Tums, maybe Pepcid, before you progress to the proton pump inhibitor. But for EoE, it's not we're not controlling acid reflux, we're controlling the EoE. It's a different pathway than controlling the acid reflux. So unfortunately, those other things that we like to typically do in OB don't work for EoE. So the lifestyle modifications won't work, the Tums, the famotidine, that won't work. Only the proton pump inhibitors work. And I would just say, in general, we consider it a safe medication for pregnant people to be on if they need it. All right. And for EoE, they're going to need it to control that inflammation. And then we have the steroids. And again, if that's something that has worked for a patient before, reasonable to continue that during their pregnancy. We don't have a whole lot of data on swallowed steroids in pregnancy, right? We have a lot of data or more data with proton pump inhibitors because of acid reflux and other reasons for being on PPIs, but there's less data for swallowed steroids, although there's decent data in terms of asthma medications, which you can kind of think about being a little similar, where it's getting into the airway instead of the esophagus. So again, kind of supposed to be more topical as opposed to systemically absorbed. So again, if that's something that's worked for a patient before, very reasonable to be on. The one where there's kind of even less data would be the dupilumab in terms of what we should do. And I think that needs to be a risk-benefit discussion with the patient. So if they have tried all therapies before and dupilumab is the only medication that works for them, and they have pretty severe EoE that can stricture, I would argue that the benefit probably outweighs the risks and they should stay on it. But you know, if a patient knows that diet elimination works for them as well as dupilumab, but they were on dupilumab because they wanted to liberalize their diet, then it's kind of a risk-benefit discussion of, okay, well, during this phase, should you go back to a diet elimination? Kind of the concerns for dupilumab would be that it can cross the placenta. So what I've kind of counseled patients before is that if they're currently on dupilumab and are planning on getting pregnant, then we should have a meeting to kind of discuss it. But if it was kind of an unexpected pregnancy, as long as we find out in the first trimester, you know, I think we can still kind of have that risk-benefit discussion, because it takes a little while for the placenta to take over, right? And there has been some data to also suggest that the absorption across the placenta is highest in the third trimester as opposed to the first and second trimester. So it does allow for a little bit of time for us to kind of discuss it, weigh the risks and the benefits, and decide on what we should do. As for the risks of it crossing the placenta, we don't have enough data on that, but it's just something for a patient to consider if they're less risk averse.
And that's, important to note for shared decision-making for the patient, but also for if they're the OB-GYN to be in discussions with, maybe their gastroenterologist. So everyone's on the same page. That's a great point.
Yeah.
So going back a little bit, for patients that have been diagnosed with EoE, mm-hmm. Can pregnancy trigger flares? Can pregnancy trigger EoE flares?
It's a good question. I haven't seen any data that suggests that it triggers EoE flares, but it can sometimes make symptoms better. It can sometimes make symptoms worse. And hard to know if one or the other will happen or if it just all kind of stays the same. But I haven't seen any data to suggest that it can trigger it.
Right. Now, for those who may be pregnant and they haven't been diagnosed with EoE, what symptoms should they be aware of, and be recognizing maybe to visit their doctor and to talk about their doctor? And for the primary care or OB-GYN, when their patients presenting with these symptoms, what should they be aware of?
Yeah, I would say mostly difficulty with swallowing, right? I think it, when we think about esophageal dysfunction that can happen in EoE, that can be difficulty with swallowing, heartburn, chest discomfort. A lot of symptoms happen in pregnancy, with a very common one being heartburn, right? Progesterone changes and then just belly getting a lot bigger. So, I don't think it's reasonable for every pregnant person to say, heartburn, we must worry about EoE, right? Because it's just so common. But I think, if your patient is describing some difficulty with swallowing, and whenever I ask patients about that, I talk about, Do you feel something get stuck? Do you feel something slowly go down when you swallow? And sometimes patients are getting so, like they've had these symptoms forever and they're just so used to how it feels that they don't realize that it's abnormal. So sometimes asking questions about how they're doing modifications. So like, are you always the last one at the table? Do you always need a water chaser with your food to get things down? And they're like, yeah. And they don't realize that that's actually abnormal to always need that. Those would kind of be the symptoms of that makes me a little bit more worried to assess this.
Now, for those in the primary care setting, OB-GYN, and their patient, maybe a pregnant patient presented to the ER with difficulty swallowing, is it okay for them to get an endoscopy while they're pregnant? And what are the things that we need to know about that, or the doctors, primary care need to know about that and the pregnant patient?
Yeah, I mean, the issue isn't so much the endoscopy, right? And endoscopy is fine to do while you're pregnant. The concern is often the sedation that a patient is going to get. And, in general, whether it's any sedated procedure, first trimester and third trimester are the times that we in general like to avoid sedation during pregnancy. And then what kind of sedation should we do? So, it depends on what practice you're in for GI. Some people do a lot of conscious sedation, which is going to be, fentanyl and Versed. Other places do more propofol, monitored anesthesia care. In general, for someone in pregnancy, what I've been told by anesthesia and other people is you really want to try to avoid those benzodiazepines. So doing more of a monitored anesthesia care with propofol is the better way to go. But then the question also becomes, do we need to do an endoscopy? And are there other ways of doing it, right? So one of my big things is to try to find non-invasive or minimally invasive ways of diagnosing or monitoring EoE. We're not there yet. But one thing that some institutions do, and it's done a little bit more frequently in the pediatric side than the adult side, so sometimes you may need to talk with the pediatric side to figure out if they'll offer this, is doing an unsedated transnasal endoscopy. So all it requires is a little bit of topical anesthesia into the nose just to help numb it up a little bit to make the patient a little bit more comfortable. And then it's a really thin tube that'll just go down their nose into the esophagus and take some biopsies. So it's not a large enough camera for us to really assess for narrowings. We can't do dilations during it, but we could at least take biopsies and see, is the current treatment working? Do they have a new diagnosis of EoE? So it could both be used as like a new diagnosis as well as monitoring response to therapy if someone is already on treatment.
So if I was your colleague, an OB-GYN doctor, and I came to you and said, I think this patient may have EoE. I'm not sure. Can we wait till after the pregnancy to determine next steps and actually do an endoscopy and figure out if this truly is EoE? Or what can I do in the meantime for this patient? Or would I refer them to you, the GI?
Really good question. What I would say is I would want to meet them or just talk through the OB to kind of see, but it depends on how severe the symptoms are. I mean, if someone is having a legitimate food impaction, they have to have an upper endoscopy regardless of their pregnant status. Just because if the food is really stuck there, that can lead to a perforation and a lot of complications. And if someone is having significant enough symptoms where, they can hardly get, soft foods down, then yeah, maybe we need to consider it sooner rather than later. But if a patient is just kind of having occasional symptoms, overall is doing fine with a normal diet, then I'd say, let's wait. We can do it, when you've delivered your baby, and let's not forget the postpartum period, right? So it's not going to be immediately after the baby. Right. I always tell patients that. I was like, you say that you're going to do it right after, but I've had a baby. I know. It's going to take a few more months afterwards before you want to do upper endoscopy. And then, I would have to talk with, the radiologists and, my OB colleagues about this also, but, could consider doing some x-rays with oral contrast to kind of assess how narrowed does the esophagus look. So that's called an upper GI series or an esophagram, where they kind of help descend open the esophagus with some contrast and effervescent granules. Typically we say some x-rays are fine during pregnancy, and I would assume that the contrast that we use would also be fine during pregnancy, but that would be a a non-invasive way. It doesn't give you a diagnosis of EoE, but it could at least tell you, is there significant narrowing? And if there's a significant narrowing, then that's going to push you to do an EGD during the pregnancy. And then you could kind of decide on the timing of it based on what trimester they're in.
So it seems really important to have that conversation between the OB-GYN or primary care provider and the gastroenterologist, even if it's just a consult with the OB, just to kind of walk through things, seems to be key here.
Absolutely. Absolutely.
Okay.
And as someone who's been pregnant before, your OB is the end all be all, right? So you definitely want their input for anything, because you want to have a healthy pregnancy and you want to have a healthy baby. So absolutely.
Now, one of the things you mentioned for EoE treatment is diet elimination. And again, there's patients who've been on it, they know what foods are their triggers, but nutrition would be a big concern during pregnancy. So what is your advice for primary care providers, OB-GYNs, and patients about that nutrition component?
I would say, pregnancy or non-pregnancy, having a well-balanced diet with sufficient, appropriate nutrition status is important. And having to eliminate certain food groups does not mean that you can't have a good nutritional status. And if there are any concerns about that, right, then we just make sure that, I work very closely with a dietitian who does a lot of work with EoE. So kind of working hand in hand with a dietitian can be very helpful. And then, you're going to be on a prenatal vitamin no matter what. So, making sure that you're, taking your vitamins and all of that. But overall, it really shouldn't affect the nutrition status too much. I think what can be challenging is sometimes I'll have patients who have food allergies in addition to their EoE, right? And those food allergies, may not be their trigger to EoE, or they may have additional triggers. And so some patients will be eliminating whole food groups because they have anaphylactic food allergies. And then we're talking about potentially doing a diet elimination. We're like, I don't know what I would eat if I eliminated more food groups. So again, kind of regardless of, pregnancy status, you do have to kind of think about that in general. But if someone only has, 1 or 2 food groups that they would have to avoid, I don't have concerns about them being able to get in the right, vitamins and protein and those types of things.
So let's talk about the genetic component of EoE. There may be moms or moms-to-be who have EoE, and they may be wondering, is EoE genetic? Mm-hmm. And then, what do the primary care, pediatric providers, and OB-GYNs need to know about the genetic component of EoE?
Yeah, absolutely. So it's not there's clearly a genetic association, but there's not a clear inheritance. So it's not, autosomal, dominant, recessive, it's not X-linked, nothing like that. But we do know that patients who have EoE, there's a higher association of family members having EoE compared with non-EoE patients. And then it seems like it's kind of a two-hit phenomenon where there may be some sort of genetic association, but there has to be some other trigger that kind of helps unveil your EoE. So some environmental trigger in addition. So, and what I mean by that is there have been studies that have looked at identical twins and non-identical twins and siblings. All right. So when we see the non-identical twins and siblings, the non-identical twins have a higher association of EoE, them both having EoE, than just siblings. So they have the same genetic composition, right? So you would think that should be the same. They're non-identical. You would think that the, increased risk of having EoE should be about the same, but it's not. So clearly something during pregnancy, clearly something during the, early infant stages can kind of predispose patients to getting EoE. But in general, it's still really low. But it's high enough that I would say to, whenever I meet patients who have EoE, to just kind of talk with them and say, anyone else in your family who may even have subtle symptoms of difficulty with swallowing or things like that, and just kind of suggest that they should be evaluated by someone. But it is different from celiac disease, right? So if someone has celiac disease, it's part of the guidelines where we say we should screen other family members for celiac disease. Our incidence isn't high enough to suggest that.
Interesting. So this is an important question for our primary care and OB-GYN and pediatric providers and for parents. How common is EoE in babies, infants, and what are the signs? We've talked to some moms of patients and they were telling us that their child was diagnosed as an infant. And I found that really interesting. What do providers and pregnant or new parents need to know about the signs and symptoms of EoE in babies?
Yeah. So for babies and for young children, I typically think about that as, less than 5, less than 8 years of age. It's not kind of the classic symptoms that we think about in terms of adults, right? Where you kind of get the food impaction where something is stuck, requiring emergency room, difficulty with swallowing, because it's clearly this disease where it's on a spectrum of it starts more with inflammation. And when that inflammation remains uncontrolled, then you'll get some more scar tissue. And you can get difficulty with swallowing with just inflammation, but it definitely becomes more prominent when you have that scar tissue that's there in the esophagus. So for infants, for babies, for young children, the presentation can be failure to thrive. So they're not gaining weight appropriately, can be just feeding difficulties in general. And it can be more nausea, well, not so much, more vomiting, bringing things up. An infant can't tell you if they're having nausea, but kind of more of the reflux. And then for, as they get older, kind of being told that they're a picky eater. So those can all be concerns for having EoE. But again, for any pediatrician out there, we all know that, kids can have some of these symptoms without it being related to EoE. So it's definitely important for you to talk very closely with your pediatrician, and not unreasonable to ask for, a referral to Peds GI to discuss it on the sooner side if there's any concern.
So for the primary care who's maybe seeing these children or these infants, when should they make the referral? When should they tell the parent that they should get a referral to a GI? When should they refer them to a pediatric GI?
So, if there's definitely failure to thrive, I think that's a very reasonable time to refer. And maybe that'll even be sooner, right? If there's, a strong family history of EoE, and we're starting to notice some subtle symptoms. My understanding from a lot of the pediatric gastroenterologists, though, is, understandably, we don't want to jump immediately to an upper endoscopy, just because that requires sedation, and we want to be careful giving sedation to, infants, to little kids. So, oftentimes it's kind of seeing, if we kind of change the diet, if we put you on a famotidine, if we put them on a proton pump inhibitor, do things get better? And then at some point, it may just be pulling the trigger and going ahead with the sedated endoscopy. I am not a pediatric gastroenterologist, so maybe my colleagues over there won't be happy with me saying it, but I think it's reasonable to refer if there's any concern or suspicion. I think there should be a lower threshold for referrals to any specialist than too high of a threshold.
No, that's great. Well, you've been really informative for our listeners. And before we close out, Dr. Beveridge, do you have any other tips or offer any advice for any other considerations for primary care OB-GYNs, pediatric HCPs to share with, or what should they be doing to monitor their patients?
Yeah, I think just having, open communications with your patients about what their diagnosis is, how they want to treat it, to feel free to refer to gastroenterology. If I'm seeing the patient, I'm more than happy to, discuss with my, fellow OB to see how we can best take care of the patient. And then, for EoE, it's typically a non-emergent disease, right? at the end of the day, yes, we want to control the inflammation. But I've definitely had patients where we just say, let's put things on hold in terms of, I recently had a patient who wanted to start a proton pump inhibitor for her EoE, and she had been having a really hard time getting pregnant and was about to go down the IVF route and spontaneously got pregnant, which was very exciting for her. But it happened before we got to do her endoscopy to see if a PPI worked. I offered a transnasal endoscopy, which she would rather not do, which is reasonable. And so we're just kind of keeping her on this dose. It only works 50% of the time. So is it working for her EoE? I don't know. But it was kind of a risk-benefit discussion of, it's reasonable to be on something than nothing. And hopefully this controls the inflammation. And then when you're done with this pregnancy, then we can kind of assess at that point and switch treatments if we need to.
Well, thank you. I really appreciate your time on this episode. Thank you so much, Dr. Beveridge.
Thanks for having me on.
Thank you for listening to the Gastro Girl podcast. For more information and resources, please visit gastrogirl.com. Do you have a question for Gastro Girl? Please email podcast@gastrogirl.com. The information, opinions, and recommendations presented in the Gastro Girl podcast are not a substitute for medical advice from your healthcare professional. Please consult a licensed clinician in your state regarding all matters related to your health.